This is Professor Ariel Ortiz Lagardere, streaming live from the International Bariatric Club Studios, and I am delighted to announce that today is the 128th IBC University of Oxford Surgery webinar. The IBC University of Oxford webinar series is a collaboration between the IBC and the Nuffield Department of Surgical Sciences, University of Oxford. The aim of the webinars are to provide free and first-class surgical education globally to improve patient care. In addition, the University of Oxford has allocated September 15th through the 17th of 2026 as the dates for the 7th IBC University of Oxford World Congress being held at the Examination Schools, University of Oxford. For more information, go to ibcclub.org. The theme of today's webinar, which will be streamed via the IBC TV tab on the IBC website, ibcclub.org, is Should Every Sleeve Gastrectomy Be Done Robotically? And will feature experts from the United States, France, Brazil, and Italy. The IBC University of Oxford webinar partnership would like to thank Zoom Video Communications, Laparoscopic Surge, Bariatric News, and Bariatric Channel for setting up and promoting this regularly scheduled online academic series. We would also like to thank our platinum sponsors, Johnson & Johnson MedTech, X&Y Medical, Arthrex, Reach Surgical. Our gold sponsors, Medtronic, Blue Sail Surgical, David Medical, McConvey, ConMed, Carl Storz, Teleflex, USGI Medical, GI Windows. Our silver sponsors, Easy Search Medical Arabian Co. Our bronze sponsors, Olympus, Intuitive. The chair of today's webinar is Dima Havaleshko from the United States. Dr. Havaleshko is Vice President of Medical Staff, Medical Director of the Center of Weight Management and Bariatric Surgery, and Chair of the Robotic Surgery Committee, Wentworth Douglas Hospital, New Hampshire, United States. I will now ask my good friend, Dr. Havaleshko, to introduce our esteemed moderators.
Thank you, Dr. Ortiz, and it's such a pleasure to chair the session with you, and so glad to see our moderators here. It's going to be a great session, and I think as robotic bariatric surgeons, we kind of know the answer to this question, if every sleeve needs to be done robotically. But what we're trying to do here is to literally prove this with data or disprove it. So let's see how it goes. And I would like to introduce my good friend's moderator, Dr. Ben Cadiere. He is a consultant, minimally invasive surgeon, bariatric and robotic surgeon, Digestive Surgery Institute, Zong, Saint Laurent du Voir, France. And sorry, excuse my Ukrainian French. Also, Dr. Paulo Bernante from Italy. He's Associate Professor of Surgery, Alma Mater Studiorum, University of Bologna, and Director of Metabolic and Bariatric Surgery and Upper GI Surgery Program in Bologna, Italy. He's also a head of the Center for Metabolic and Obesity Surgery of the University Hospital of Bologna Policlinico di Sant'Orsola in Bologna, Italy. And our third moderator is Professor Paula Volpe from Brazil, and she is a consultant gastrointestinal bariatric and robotic surgeon, São Luís Itanim Hospital, São Paulo, Brazil. And Professor Bernante will introduce our first speaker.
Thank you, Dima. It's a great pleasure to introduce our first speaker. Maria Altieri is Associate Professor and Section Chief of Gastrointestinal Surgery and Director of Bariatric Surgery at Penn Medicine, Pennsylvania Hospital in USA. Maria, please on stage.
Thank you so much, Dr. Bernante. And good morning, I guess, good afternoon, and good evening, depending on where you're in the world, as I recently kind of learned that this is going to be all over the world. So thank you so much for the opportunity, and thank you to the moderators and the IBC. And I feel like this topic is very timely, especially as we're evaluating how we're training our next generation of surgeons here, specifically in the US. I have no conflict of interest. I do have to say that I do perform both laparoscopic and robotic sleeve gastrectomies. And I pick and choose how I would like to perform these cases. I would like to tackle these cases based on individual patient. So the goals of my talk are to review the technical differences between robotic and laparoscopic sleeve gastrectomy, compare perioperative outcomes and complications, Also compare costs and financial impact, specifically on the hospital and the healthcare system, and also suggest some practical guidance on selecting an approach. As I mentioned, I feel like this is coming very timely, as at least in the United States, we are wondering if more residents are actually being trained on the robotic assisted surgery, and I feel and are being more proficient compared to laparoscopic surgery. So that's why I feel like it's such an important topic. So sleeve gastrectomy is the most commonly performed procedure for bariatrics worldwide and in the United States. So in the US, we perform roughly approximately 160,000 sleeve gastrectomies per year based on the most recent NBSA QIP numbers. Now, it has gained popularity due to its technical ease, also comparable weight loss and safety profiles. And the number of robotic bariatric procedures has significantly increased with claims of improved ergonomics, articulation, visualization. And the robotic adoption is growing, and yet benefits remain debated. So an article that was just presented last year, 2024, as a top ASMBS paper, compared or trended the robotic utilization from 2015 to 2022, and you can see there robotic sleeve gastrectomy increased by 624%, which is pretty impressive. Another article that just got published this past month in Annals of Surgery, again trended robotic utilization from 2012 to 2020, and again showed an increase of by 250,000 in terms of robotic sleeve utilization. Now, that kind of makes me feel that in the last 5 years, the uptake of robotic procedures has significantly increased. This is also highlighted in a paper by Maria Altieri, a fellow Pennsylvania bariatric surgeon, just showing you that following revisional bariatric surgery, the highest growth in robotics in bariatric surgery has been with sleeve gastrectomy, as you can see here. So what are some of the differences between laparoscopy and robotics? Well, let's look at how they differ. In laparoscopic sleeve gastrectomy, you already have the established trocars. You have straight instrumentation, and it's two-dimensional. It's a surgeon-assisted stapling, and you have the surgeon and the assistant, so you do have to rely on your assistant. Whereas robotic sleeve gastrectomy, you have the wristed, like the 360 wristed instrumentation. It's a 3D visualization, so a little bit better visualization. If a surgeon does have a tremor, then that is actually being filtered. Also, the console is actually being controlled by the surgeon, as the surgeon controls all arms. And in some cases, it can simplify suturing and also can help with more complex cases in terms of like hiatal hernias or revisional work. Now, when I start to give this talk, I went through the literature, and I have to tell you that, you know, like when we discuss a specific topic, most of the data is actually on retrospective, non-randomized, a lot of variation, you know, studies. And it's either single surgeon experience or single center, several institutions, or data that is not really clinically rich, such as database research. I also wanted to, you know, bring up the point that there is rapid technology changes, such as newer platforms that are coming out, newer staplers, and so the outcomes can differ over time. So that makes it a little bit challenging in terms of analysis. So let's look at some of the outcomes. So in terms of operative time, a robotic platform has been associated with longer operative times in most pooled analysis. And this is most likely due to learning curve, docking, undocking, and also exchange of the instruments as well. And in fact, one of the studies actually showed about differences between 20 to 30 minutes higher operative time for robotics. And why does this matter, right? Why is this important? Well, because extended operative time is actually directly associated with a longer hospital length of stay. In some studies, it was shown that each additional hour of surgery has been linked to 64% increase likelihood of overnight admission. Also, it is associated with complication rates, right? Increasing complications. One study specifically showed that every 30 minutes increase in operative time, there's an increase in complications by 14%. And if it's by hour, like so an increase in an hour, that increases to 21% odds of increase complication rates. Something I do have to mention, though, and this was actually presented at the IBC in 2023, is that the operative time can decrease over time with experience. And perhaps for an experienced surgeon, operative time may be the same for between laparoscopy and robotic cases. And one has to worry about the prolonged operative time with the learning curve only. So how about hospital length of stay and immediate recovery? Well, most studies show similar or slightly longer hospital length of stay for robotic procedures, robotic sleeve gastrectomy, but differences are so small and variable, so nothing really different there. In terms of complication rates, so recent meta-analysis and registry analysis often report equal or lower complication rates for sleeve gastrectomy, for laparoscopic sleeve gastrectomy, with some studies showing higher early complications with robotic sleeve gastrectomy, but that's heterogeneous, like the evidence is all over the place. And overall morbidity also, again, no advantage for robotic sleeve gastrectomy, and some show actually laparoscopic sleeve gastrectomy with lower overall complication odds. And those include leaks, bleeding, readmission rates. This can be very, very difficult also to compare because our complications at this point are actually pretty low. And so the analysis might be also difficult. Like you need a lot of data to show differences. So some of the studies, this is the paper that was published in SOAR last year. It was a top ASMBS paper, just comparing robotics versus laparoscopic in its 8-year analysis, again, NBSA QIP data, but it has close to 600,000 sleeve gastrectomies. Again, so comparing laparoscopic versus robotic sleeve gastrectomy, robotic sleeve gastrectomy had significantly higher overall morbidity, leak, and bleeding rates. Another paper that was published back in 2020 was it was presented at SAGES, and again using the NBSA QIP registry, 50,000 robotic procedures, close to 600,000 patients, and again laparoscopic sleeve gastrectomy was associated with decreased anastenotic staple line leak, less 30-day readmissions, 30-day reintervention, overall events, and also extended length of stay, so lower hospital length of stay. Across the board, laparoscopic surgery was associated with decreased operative time as well, which is not a surprise. This is the paper that was recently published in Annals of Surgery from the Michigan group and 120,000 patients, a national claims database. So over the 7 years, there were no differences in adjusted hazard ratio of complications, hospitalization, emergency department use for intervention, revision between the two groups, laparoscopic versus robotic. But the robotic approach was associated with a higher 7-year risk of reoperation for both procedures, meaning for robotic sleeve gastrectomy and robotic Roux-en-Y gastric bypass. In terms of like weight loss and long-term outcomes, there's actually not really any difference, and long-term data is actually very, very limited. So let's take a look at cost. So this was a paper, again, from the United States. It was comparing laparoscopic versus robotic sleeve gastrectomy. So a total cost analysis showed average cost of $7,000 for laparoscopic sleeve gastrectomy and an average of $11,000, close to $12,000 for robotic assisted sleeve gastrectomy. Now, what the reimbursements were, and this was a little bit strange because they were the same procedure and there's just the same CPT code with like a modifier. The reimbursement was actually higher for the laparoscopic sleeve gastrectomy versus for the robotic by about like $2,000, close to $3,000. So which translated to an average contribution margin of $14,000 for laparoscopic versus $6,000 for robotic assisted. So this is what you get, or what the hospital is getting following the procedure. This is a paper by Ben Clapp examining exactly this, like why does it actually cost more? And the cost drivers were the longer operative time, the disposables, the robotic disposables, and also the maintenance and depreciation of the robotic platform. So if you're a hospital, right, if a program is already owns a robot and has OR efficiency, marginal cost per case decreases, but robotic sleeve gastrectomy usually reduces contribution margin compared to laparoscopic sleeve gastrectomy in most of the published cost analysis. So if you are a administration or the hospital system, you need to consider centralizing more complex cases to the robotic platform. Also standardized stapler strategies, supply contracts to control the cost. So one topic that I wanted to bring up that I feel like we're not discussing enough, and that's the effect on us as surgeons and the effect of the robotic platform on our well-being and also prolonging our professional life. So personally, that's my story. I wasn't trained on robotic bariatric surgery. I actually adopted that like following my joining in East Carolina University back in 2021. At the start of my career, my patients were very, very high BMIs, BMI 60 to 90 range, and that was in North Carolina. And so every evening I came home and complained about the stress that put on my body. So I feel like the robotic platform improves the ergonomics from that standpoint. And here's a study that showed that the robotic bariatric surgery basically leads to lower risk ergonomic stress compared to medium risk stress when cases were performed laparoscopically. It's a very small study. Thus more data is needed, but personally I decided on how to do the cases, anticipating the stress on my body, such as higher BMI, more complexity, etc. Another study, again, Dimitrios Stefanidis group with, again, small number, 20 surgeons and trainees, and showing that the robotic-assisted surgery led to lower postoperative discomfort and muscle strain in both upper extremities, particularly dominant side of the surgeon, but increased static neck positioning with subjective back stiffness compared to laparoscopy. So you have to be aware also that the robotic system can also put some stress on your body, which is a little bit different than the laparoscopy. So this is my preferred decision framework. It's pretty simple. So any primary straightforward sleeve gastrectomy in average BMIs, like BMI about like below 50, I would personally perform a laparoscopic approach. It's shorter over time, lower cost, equivalent outcomes. If I do have higher BMIs, patients with more complexity, such as hiatal hernia or revisional surgery, I will actually choose the robotic approach. And then for institutional level view, if the robot is underutilized, push more complex cases towards a robotic platform, but then also make sure that you run some cost and outcome audits every 6 to 12 months to just kind of evaluate. So key takeaways. So the robotic sleeve gastrectomy is increasing. The utilization of the robot is here to stay. And operative times are generally longer for robotic sleeve gastrectomy. However, that difference might decrease with passing that learning curve. Robotic versus laparoscopic surgery seems to have similar overall complications and long-term outcomes, and robotic sleeve gastrectomy has a higher cost per case compared to laparoscopic sleeve gastrectomy. And personally, my advice is I personally reserve the robotics for more complex cases, revisional cases, but we still need to examine outcomes and costs. So thank you so much, and I look forward to the discussion.
Dr. Altieri, it was a great presentation. Thank you very much. I'm still making my mind about which way to go right now based on your data. But I'm wondering, what do you think about the concept of when sometimes we as surgeons saying, well, if you're going to do just complex revisional robotic cases, how about use your less complex cases in getting better at the robotic technology? Because this is completely different than laparoscopy, right? It has its own ways of doing it. So I almost personally feel that sometimes I would be kind of a little bit cautious when surgeons just say, I just do complex revisional robotic cases. And you need sometimes to use these cases to train yourself for that, to be ready for complex cases. And I think robotic surgery also adds, and nobody is calculating that, surgeons' years that surgeon can practice, as you stated, based on, a proof in ergonomics and everything else. What would you say?
No, I agree with you 100%, Dr. Havaleshko. And I didn't mention this, but in the beginning, my first cases on the robotic platform were actually lower BMI, less acuity, until I was very comfortable with the platform. And so for anyone who is thinking about dabbling into, starting a robotic practice, I think that that's very important. That's a great point that you made. So start with a lower BMI, less complexity, and then advance as you feel more comfortable with it. And that's the other thing, right? For now we're having Intuitive as the only platform right now, but we're going to start also seeing some of the newer platforms. And same advice I would have for that. Even if you are very, very well trained on Intuitive, I still will get my level of comfort with the newer platform, so to ensure that I have good outcomes. And I also, not just that, but I feel more comfortable when it comes down to like actually having to do more complex cases.
Thank you. Dr. Cadiere, do you have any questions for Maria? All right. Maybe Professor Volpe, you have questions for Dr. Altieri?
No, I totally agree with her. Totally agree. We have to train a lot in these simple cases to get more complex cases. There is no way. We have to train in these easy cases.
Correct. It's a different technology, and we have to be versatile with every technology. But she's right. If the light goes off and computer breaks, we still have to be able to finish the case laparoscopically.
Yes.
Yeah, so that's one of the, like the questions here, right? Like how are we training our next generation? Because not everybody has the access to the robotic platform. And the proficiency of laparoscopy, at least in the United States, is kind of going like, it's lower for laparoscopy than for robotics at this point, I feel. I don't know. That's my personal feeling.
Thank you.
Sorry, Dima, I was out with my audio. Can you hear me now?
Yes, we can hear you, Ben.
Yes. So yes, I had I had a question to Dr. Altieri. I saw which were your decision points on whether it's going to be high BMI, it's going to be a complex procedure, revisional procedure. I was going to ask a little bit of a tricky question. Is the socioeconomic situation of the patient going to be a factor or not?
No, usually we actually don't, that doesn't come into effect in this algorithm at all. At least we are kind of like separated from that part as surgeons, which is great. And so none of the decision tree actually is affected by the socioeconomic, at least not in the United States. I'm not sure about the world, but not in the United States. And Dr. Havaleshko can also, chime in as well. But I don't think that comes into effect in any of our decision making here.
Absolutely, I agree, because we, Ben, don't even sometimes know if the patient has insurance or not. I personally never check. I rely on, I hope it's done before me, and we're just focusing on delivering medical care and surgical care to patients, because I personally don't even know who has what.
That's great. Thank you very much.
All right. Professor Volpe, would you introduce Dr. Diego Camacho?
Diego Camacho, the versatility, cost effectiveness, and safety of Robo-laparoscopy sleeve gastrectomy surgery. Dr. Diego Camacho is the director, minimally invasive and endoscopic surgery and associate professor of surgery, Albert Einstein College of Medicine and Montefiore Medical Center, New York, USA. Please, Dr. Camacho.
Thank you very much. Can you hear me? And I'm sharing my screen.
Yes, we can.
Well, thank you very much for the moderators and the chair, Harris and Ariel, for the invitation. It's an honor to be here presenting with such a great panel of speakers and moderators. So today I'm going to be talking about the versatility, cost a little bit, and the safety of robotic surgery. I don't want to cross too many lines with Dr. Altieri's talk because we have a lot of things, a lot of topics in common. But so let's start with my disclosures. I am a true believer of laparoscopic surgery with an open mind towards robotic surgery. I've been practicing bariatric surgery for over 25 years, and I adopted robotic surgery, I would say, 6 years ago. So I think that you have to come with an open mind about robotic surgery if you're a fully trained laparoscopic surgeon. So this is what I'm going to be talking: versatility, cost, and safety of the procedure during robotics. As Dr. Altieri said, around 175,000 cases are going to be or were performed in year 2024 in the United States. It's the most common procedure performed around the world. So let's start with my first slide. Never say never. 7 or 6 years ago, if someone would have asked me, are you willing to give a talk about robotic surgery? I clearly would have said, no. I don't think that we need robotic surgery at all in our practice. A few months back, and this is a good friend of mine, and many of you know him as well, presented this slide in one of our meetings in Central America, and how still laparoscopic surgeons are fighting back against robotic surgery. Laparoscopic surgeons feel that they don't need the robot. They go crazy about cost. And it's not cool to do robotic surgery. And the robotic surgeons, they care less about the data, no matter how many papers come out saying that it's more cost, that it takes longer time, the learning curve, they still practice it. They feel like sometimes the robotic gives them extra power and abilities to do these complex bariatric cases, and that a non-skilled surgeon can become a very skilled surgeon using Da Vinci. So I don't know if that's true anymore. I truly believe that it depends on the surgeon. I think that a good laparoscopic surgeon will become a very good robotic surgeon. So when I talked about offering robotics versus laparoscopic sleeve to my patients, I want to compare apples to apples. It's not only about me right now. Everyone talks about the well-being of the surgeon. Are we doing this just because the surgeons are improving their quality of life? They feel better, less pain. But the truth is that we have to look at the patient as well. Are we offering the same results that we were offering to laparoscopic sleeve gastrectomy? So let's talk about the versatility, straight instruments versus all the benefits of robotic surgery. This is me on the right side doing a sleeve gastrectomy, very comfortable, standing 180 degrees on my hands, looking straight. So I don't think that I'm in any stress, as you can tell. Or is it better to be doing it sitting, using your jacket, warmer? You can answer your text while you're doing the robotic surgery. Here is my fellow operating on the right side. I let him do cases so I can answer my text, I can answer calls, I can go to the bathroom. So let's see if it's worth the changes. So first, let's look at this. The video, as I said, my fellow looking at the person that was taking the video, I'm doing an inguinal hernia here, but as you can tell, we're both sitting next to each other, the system on the right side. Now, the only one that it's not having a great time, I think that it's our surgical tech here, because she's waiting for 40 minutes to get the orders what to do with the instrumentation, correct? So let's look at how laparoscopic conventional instruments work. Straight sticks, you can only rotate 360 degrees on the tip of the instruments. But again, you can see that it's a clean surgery. There is not much to fight for, unless you're doing those high BMI patients where you definitely are using a lot of torquing in your instrumentation. But as you can tell, I mean, laparoscopic surgery has very good versatility when you're performing the sleeve gastrectomy. When we talk about the stapler, that's a different game, I would say, because when you use the power staplers or any mechanical staplers, you can only rotate up to 45 to 50 degrees on your reticulation. I'm completing the sleeve. I like to use covered staplers, but you see, we're not fighting, we're not having any issues, and I think that the surgery can be performed safely. Now, can we transmit this safetiness to the patient when we're doing robotic surgery? So let's look at now how things are different. Robotic surgery allows us to roticulate and articulate the instrumentation 120 degrees up and down. You can come from right to left, left to right, top, bottom. So the dissection is much easier. The visualization with the camera, for those that have been exposed and are using Da Vinci, it's fantastic. The 3D visualization definitely makes a big difference. As you can tell, again, you are not fighting. You're using the same dissection. The technique is pretty much the same, except that you're using different modality to perform the surgery. The articulation of the stapler, again, you can really come up and down, roticulate it a little bit more forward, a little bit less traction. So to me, I think that this is a very comfortable and very easy way to perform a safe sleeve gastrectomy. So let's see if the data supports this. This is a very good article from Australia that they sent a questionnaire to around 323 surgeons asking different questions about sex, height, weight, dominant hand, and many other questions that you're going to see here if you want to look at the paperwork. Interesting, they were asking about personal things about the patient, about the surgeon. How do they feel after the surgery? If they had more tiredness, if their backs were hurting more, if they changed the outcomes of the surgery because they were having issues during the procedure, either laparoscopic or robotic surgery. Now, these are the results. More males answered the questionnaire. Of course, years of experience in the robotic group, there were more than 0 to 2 and more 10 to 15 in the laparoscopic group. And these two tables are very important. As you can tell on the left side, it's in regards to the pain. Green favors robotic the answers. And as you can tell, the robotic platforms show better outcomes in regards to pain compared to laparoscopic. In regards to versatility, asking surgeons different questions, blue means positive, red means negative. Pretty much the same results when they were asking surgeons if they have any complications during the surgery, if they change their outcomes, if they change the procedure that they were performing. So this is what they concluded, that 33% of the surgeons that were doing laparoscopic surgery were complaining of neck pain or shoulder pain. 21% of robotic surgeons were complaining of neck pain. And I think that this is going to decrease with the new technology of the DV5, that now you can look in a straight fashion the camera and the surgery. So let's talk about, as Dr. Altieri was saying, the Achilles tendon, the cost of robotic surgery. Many institutions these days are analyzing the data and are looking very close because the financial outcomes of robotic surgery, it does not favor sometimes the institutions. So they're pushing the surgeons to either come up with programs that analyze which surgeries should be done robotically and which ones should be done laparoscopic. So we know for sure, and many papers have proven this, that robotic surgery is more expensive. But if this is a myth, so let's take a look at this article published in 2025. It's a meta-analysis coming from Switzerland, looking at 14 retrospective studies using the Robinson's data analysis to evaluate the results. 1.4 million sleeve gastrectomies, more in the laparoscopic group compared to the robotic group. And this is what they found, that the laparoscopic definitely was associated with at least 5 or 6% more less cost expensive compared to robotic surgery. Close to $4,000 in this retrospective review showed this data. So they concluded that robotic surgery still remains more costly compared to laparoscopic surgery. This other study published in 2024, this is from NYU Brooklyn, 3 systems looking at the MSN data from 21 to 23, looking at the CPT codes and ICD for billing, and they found that there was a 4% increase in total charges. And these are the 3 reasons: due to higher OR charges in the supplies, OR time, and more post-op visits overall. This other study published by Dr. Elshar, this is a very small single institution, 45 robotic versus 29 laparoscopic from St. Luke's. And he looked at paraesophageal hernia repair concomitant with sleeve gastrectomy. And interesting, If the patients that underwent the paraesophageal hernia repair during the sleeve gastrectomy, it had a higher cost in laparoscopic. The overall cost at the end was more costly in the robotic, meaning OR time, cost per minute of the surgery, and recovery and hospital stay. But when they were comparing with patients that did not have paraesophageal hernia repair, the cost of laparoscopic surgery was more expensive, but overall, the robotic was less expensive compared to laparoscopy. So it's a little bit mixed data here. But they concluded that definitely robotic surgery has a higher cost overall when compared both surgeries, sleeve with paraesophageal and sleeve and no paraesophageal hernia. So let's talk about safety. And this is a very important topic to me, because I think that if we're going to offer this to the patients, not only looking at how I feel, if I'm going to feel better, my back is not going to hurt, if I'm going to offer the same results to my patients, you know. So let's look at this study published in 2024, a group from Mayo Clinic looking at 2015 and 21. And the title is very, very important. Are we improving the quality and safety for these patients? So they divided the study in two groups, one from 2015 and 18, 19 to 21, close to 800,000 sleeve gastrectomies. In the first 4 years of the study, they looked at the results, and definitely there was a higher incidence of leaks robotically, longer OR times, and length of stay. The last 3 years of the study, 19 to 21, there was a reduce in the leak rate as well as the length of stay and OR time. Last but not least, Dr. Santiago Horgan in California. This is his paper published last year, retrospective analysis from 15 to 22, close to 600,000 sleeves. This paper was described already by Dr. Altieri, more laparoscopics than robotic, and they compared the OR time, length of stay, and morbidity. As you can see, in 2015, the average time was 97 minutes. 7 years later, it went down to 20 minutes. The laparoscopic sleeve gastrectomy also went down, but not as much as the robotic surgery. The laparoscopic gastric bypass group was the same, but not as much as the sleeve gastrectomy. In compared to the morbidity during the first 30 within the first 30 days, Dr. Altieri was mentioning, there was a little bit higher incidence of morbidity, leaks, and bleeding. But I think that the bleeding changed dramatically since we have been using and changing the color of the staplers. I remember using blues all the way up from the beginning, all the way up to the angle of his, and now changing the blue to whites. People are using only white, so that has to do a lot. People are oversewing the staple line, so I think that the bleeding has decreased tremendously. So even though there was some differences statistically, definitely there were no clinical significance, less than 1% versus less than 1%. So my conclusions, well, I think that in regards to ergonomics and versatility, robotic surgery is a more superior way to perform sleeve gastrectomies, especially in very large obese patients. In regards to the cost, every institution has different contracts. We already talked a little bit about what the prices are going to be in the US versus South America or Europe. I think that for us, we're seeing that the prices and the cost is going down, but still the cost of robotic surgery is a little bit higher compared to laparoscopic. And in regards to safety, I think that as you saw before, I think that the results are comparable. Good results, same morbidity and mortality compared to laparoscopic surgery. Thank you very much, and I'm willing to take any questions. Thank you.
Dr. Camacho, great presentation. Thank you very much. And I love your confusion that everything is comparable. It's not that, different.
Yeah.
A nice, beautiful staple line on your videos. I just don't know what that metal thing is under the liver holding the liver. I don't know what it is, but I'm kidding. But what I want to ask you is your personal opinion, because data is data. We have to believe it. But I think we're comparing sometimes, like you stated, apple to oranges, even in terms of our length of doing one procedure versus another. We are comparing surgeons that are doing laparoscopic surgery for 20, 30 years, and now they started doing robotic, and we compare that. However, what I noticed personally that I'm actually, and I feel in my hands, I was recently helping with some cystic duct was ripped by some acute trauma surgeons, and they were asking me to fix it laparoscopically because that was laparoscopic case. And I'm like, oof, I forgot when the last time I was doing suturing laparoscopically. But when I went in, I actually had a weird feeling that I see the anatomy, and the camera was nice and clean, Stryker, beautiful laparoscopic camera. But I felt that I was seeing that anatomy in 3D. So I'm wondering to myself, like, am I crazy seeing in 3D? It's a 2D camera, right? I think we're so used to seeing some image in 3D that our brain almost compensates for that. So my point is, what do you think about laparoscopic surgeons when they have to go back to laparoscopy are slightly better surgeons because they saw anatomy so closely and nicely?
That's a very interesting question. I will say that, once you transition from one surgery to the other surgery, it's like riding a bicycle. You started with a very simple bicycle, and as during your career now, you're using this very high-end bicycles, and you're racing these big races. But the basics are always going to be the same. You will never forget the basics. So I think that when you are going from robotic surgery to laparoscopic surgery, you will immediately, your instinct will kick in, and you're going to be able to do it safely. Now, the biggest question that I'm having right now is we have 10 residents in our program and 2 fellows, and it's so hard because they all want to do robotic surgery. They all want to do robotic surgery, and they are forgetting that there has to be times where they have to learn how to do open surgery. They have times that they have to learn laparoscopic surgery. And what's going to happen when they have to go from robotic surgery to what? Laparoscopic? I don't know if they will have the experience. I don't know if they're going to have the experience open. So that's the $1 million question, and we're seeing it more and more when you interview fellows at your programs and you interview residents. They all want to do robotic surgery. I think that the platforms, everyone knows about robotic surgery, but laparoscopic surgery should be part of, and that's why I said I'm a truly believer of laparoscopic surgery, but you have to have an open mind when it's time for you to transition. Robotic surgery is here to stay, is going nowhere, and like it or not, my generation of surgeons, I have seen that they are fighting against robotic surgery. We don't need it. We don't have to do it. And I'm going to give you an example. I have my boss, Scott Melvin, who was one of the pioneers in robotic surgery. He did first, Heller myotomy, appendectomies robotically. And you ask him, and he said, like, you don't need to do robotic surgery because you're good laparoscopic. So going back to your question, I think that robotic surgery will make you a great surgeon. And if you have to go back, your instincts of laparoscopic surgery will kick in immediately.
Thank you. Any other questions from our moderators?
Yes, Dima, thank you. Dr. Camacho, great talk. I agree with you a lot. My question is, outside the US, new robotic platform are coming in the market, and they are cheaper and so more affordable from our hospital administration. In Italy, for example, we have the Medtronic Hugo robot, but from China, a lot of new platforms are going out. And all of this platform, probably all of this platform right now don't have a robotic stapler. So my question to you is, what do you think about doing a robotic sleeve gastrectomy without a robotic stapler?
That's a very good question. And actually, I trained someone yesterday from Texas, from the Memorial System, how to do a hybrid surgery. So we did everything robotically. And then I used the Signia stapler to complete the sleeve. So yes, it can be done. It's been done. People are doing it. So it's a preference of the surgeon. So if you have a system that does not have staplers at this time, you can use the current staplers, Johnson, Medtronic, whichever system you want to use. But it can be done. It should not be a limiting factor if you want to start doing robotic surgery.
Yes, my experience is just the same. We use the Signa, but in my opinion, I think that probably the costs are really higher. And in my opinion, if you can use the robotic stapler, you can't appreciate the beautifulness of the robots, because you have to leave the stapling to the assistant at the table. So I think that probably is not a good option, because stapling in sleeve is really important, because you have to do a nice line of stapling. So you need a very good assistant at the table.
Correct. I have a good PA, which has been practicing bariatrics for 25 years. I will say that he has done over 18,000 cases, and I feel very comfortable. But the question of this surgeon from Texas was, I have to go back to the institution and ask if that technician can fire the stapler, because legally we don't know if that is right or wrong. So you have to make sure that if you're going to have someone firing the stapler for you, that it's not a non-physician. Make sure that the institution allows that to happen.
Thank you, Dr. Camacho. Any other questions from our moderators or from our presenters?
Just a comment. In Brazil, we use a lot of a stapler with the bedside. It's another surgeon, because for us the stapling from the robot is very, very expensive here, and so the majority of cases here we perform without the stapler from the robot.
Yeah.
Maybe now we receive now the Tomai robot. It's one Chinese one, and we receive the Edge is another one Chinese. Maybe the costs get lower, and I don't know. Here our experience is hybrid, because we don't have it's very, very expensive, the robot system for us.
If it's hybrid and that's what your preference is,
Of course not.
Make sure that you use the right stapler. That's the only thing that I'm going to recommend.
Yeah, I
Use
know
the
that.
right color stapler and the right stapler. That's all.
Yeah, we know that, but it's a way to perform a lot of surgeries with the robot here, because we have only 150 robots in Brazil. So
yeah, I agree. I did a presentation at IBC for hybrid stapling, and there were mixed, comments. But now that new platforms are coming out, I think that more surgeons are being exposed to more robotic systems, but they don't have the stapling, so they have to adopt to, the hybrid approach.
Yeah.
I always say that just use whichever stapler you would like, but don't be one colored stapler, because sometimes surgeons go to either I'm all white or I'm all blue or I'm all green. No, every stomach is different. Use your judgment, have your own protocol, have your own computing power in your brain, which stapler to use, and do not rely just on technology.
Correct.
No, thank you.
Can I just make a couple of points? So personally, for me, the most challenging thing was to get kind of, comfortable with a stapler. I feel like it's very clunky, the intuitive stapler. I don't like, that was my worst. But I have seen other surgeons who have done exactly what you were talking about, use the Signa stapler, and they have been at bedside. So the resident will do the dissection, and then they'll finally fire the stapler, and they'll be bedside. Recently, I have actually tried the Titan stapler, which is one staple load. It's a larger trocar because it's a bigger stapler. And I've really liked it so far. It does have reinforcement and it comes out with a beautiful staple line. And knock on wood, for some odd reason, both patients did great. Even I was like, oh, like is I, like I was a little nervous about trying something new, but it has come out perfect. And I think that from a cost perspective, that's a lower cost for that compared to, I think it's like the cartridges for the intuitive staple are like 300 each or something like this, which is $300. And I don't know how many we use, sometimes 6 or 7 at a time.
That's one thing that I feel. And the other day I was in a meeting, at ASMBS, and we were discussing about the staplers, and I brought this up, and some agree with me and some didn't. But every time that I use the Da Vinci system, sometimes I have to fire more staplers than the regular staplers that I use laparoscopic. And the same dissection, same positioning, but for some reason, I have to use maybe another 1 or 2 extra, and you cannot go down to 45. So you can stay with the 60s. So you cannot, decrease the size of your stapler. But that's my experience. Sometimes I have to use 1 or 2 more staplers compared to laparoscopic sleeves. That add more cost to the surgery.
Dr. Camacho, do you use, which bougie do you use for your staplers?
I use a 34, the VCG.
VCG, yeah.
VCG.
Because I noticed that if the bougie is on suction, it actually stabilizes the stomach quite nicely, and sometimes you can, do not extend, because if the stomach is moving, sometimes just from like a very smooth bougie, it will be way more staplers loads. Excellent. Well,
not always. I'm just saying
always.
Sometimes you have to fire extra, like laparoscopic as well.
Which is fine, I think, for $300 to avoid some complications and overstretching. We do important things.
All right.
Excellent. Thank you very much. And I know you have to go to surgeries.
I'm sorry, Dima. There are some questions from the social media for our speaker. If you want, may I read the...
Would you like to? Yes.
The first one is from Dr. Kamil Rapax. He said, I am in the process of publishing data showing that robotic procedures offer no benefits for patients with a BMI above 60, for whom this procedure would be expected to have advantages. I would appreciate your comments on this. I don't know if probably Dr. Altieri may give an answer.
But maybe we will have the talk from Dr. Vitiello about the role of robotics on super obese. So maybe it's gonna intersect the talk and the answers.
Okay, Ben, I think that you are right. So we can go on.
Great point, Professor Bernante. Dr. Cadiere, would you like to introduce Dr. Vitiello? Ben, I think you're muted still. If not, you are.
Can you hear me better?
Yes, we can hear you.
Yes, sorry for that. Yeah, so yes, I'm introducing Dr. Vitiello, who is from Napoli. He's a specialist in general surgery, also university researcher, and he's going to be talking about what we just had a question about, which is the role of robotic surgery in super obese patients.
Thank you very much, Dr. Cadiere, for introducing me, and thank you very much, Haris, for the invitation. It's really an honor to share this presentation with such an important panel. Okay, I'm going to share my screen. Just let me see if you see it. Do you see my screen?
Not yet, but it's coming, I think. Yes.
Yeah, it's coming. Okay. Thank you very much again. I work in the University of Naples, Federico II, and I just want to, I'm trying to, okay. So first of all, I wanted to start with my disclosure. Of course, as Dr. Altieri said, I'm mostly a bariatric surgeon and I'm mostly a laparoscopic surgeon. I've done less than 100 cases with robot, but I started before finishing my training. I did the basic training and the advanced training with the company. We used the Da Vinci platform, which is the only one available in our hospital. But I must say that I think in my university, we have quite the experience with the robotic sleeve gastrectomy, because as you can see in Italy, we started 2 years ago. And as you can see in Italy, in our national registry, the registry of our national society, the rate of robotic procedures just appeared in 2024. And I was surprised, or maybe I was not surprised, to discover that the most performed bariatric procedure robotically in Italy was the sleeve gastrectomy. And I think in 2024, we made in Italy 175 cases. I think in our university we did 20 to 30% of these cases. We also published our results during the learning curve. This is not the topic of this presentation, but I just wanted to say that we had an average BMI of 42, so we had very fewer cases of super obese or super obese patients, or better, or patients with a BMI over 50 or over 60. But we tried to see if there was any difference, any correlation in between the operative time and other complications and the BMI, and we didn't see any relationship actually, and neither any difference in between laparoscopy and robotics. And if we take a look at literature, honestly, this is what we found also in the first evidences that we can find in literature. This is the article that Dr. Altieri showed us, and I wanted to also to include this article in my presentation, because as Dr. Altieri said, this article shows a very higher rate of complications for the robotic sleeve gastrectomy. But I'm from Italy. I'm not from the US. But this is an 8-year analysis, and I'm not quite sure that 8 years ago all the bariatric centers in the US had maybe the same experience they had with laparoscopy. And also you had this discussion about the hybrid procedures. In the discussion of these articles, the authors said that they compared some hybrid robotic sleeve gastrectomies to laparoscopic sleeve gastrectomies. But if we are using a laparoscopic stapler, we are just comparing apples to pears. We're just comparing staplers to staplers, to surgeons to surgeons. We are not comparing fully robotic sleeve gastrectomy to laparoscopic sleeve gastrectomy. And if we consider the average bariatric patient, if we consider a patient with a BMI over 40, so a patient who is just morbidly obese, he hasn't a BMI over 50 or 60, the literature is clear. You have no difference, no advantages, but no disadvantages with the robot. You have a longer operative time, but we'll talk about this topic later in one of my last slides. And if we look into literature and we try to see if there was any difference in between, robotic and laparoscopic approach for BMI over 50, this one analysis again of the MBS AQIP database from the US, and they showed that there was no difference, no advantages, no disadvantages in between the robotic and the laparoscopic approach. But we have also other evidences showing that the more complicated is the procedure, the more complicated is the surgery, the better maybe is to use the robot. This is an article from Italy, and yes, they are not comparing sleeve gastrectomy, they are comparing Roux-en-Y and Sadis, but it is quite clear from the literature that if you perform a complicated bariatric procedure in a high BMI patient, it just you may have better results, and it's just easier with the robot. Specifically for robotic sleeve gastrectomy, the first paper that we can find in literature is from Professor Giulianotti and was published more than 10 years ago. It was 2011. I'm sure that they were doing hybrid procedures, but still they proved an important point that if you perform a robotic sleeve gastrectomy in a high BMI patient, and we know that high BMI patients, they have usually higher rate of complications. If you use the robotic approach, you still have the same level of safety than laparoscopy. And it was not quite evident knowledge more than 10 years ago. In the following years, other articles were published. As you can see, this one is again showing that if you have a robotic assistance during a bariatric operation in patients with BMI over 50 or over 60, maybe, this statement is very important, you maybe overcome operative difficulties that you can find when you operate on a super obese or a super obese patient. This is a quite important matter because, as we can see, we always talk about stapler complications, sometimes using a laparoscopic stapler even during a robotic operation. But that's not the only point. If you're operating in a patient with central obesity, with a big amount of fat, big liver, big stomach, sometimes the robot just makes it easier. And this was quite evident even 10 years ago. These are other articles from the surgical endoscopy published in 2018, and they demonstrated that even for the sleeve gastrectomy, robotic bariatric surgery can be. This was a matched retrospective comparison, and as you can see, they demonstrated also for the sleeve gastrectomy that robotic approach for this patient with super obesity or super obesity may offer low perioperative morbidity and incredibly, surprisingly, also no increase in operative time. And this article was published, very recently, last year, another analysis, a more recent analysis of the MBS AQIP database. As we saw, we had previous analysis saying that there was no advantage using the robot platform for super obese patients. Now we have this analysis saying that if you do a robotic sleeve gastrectomy in this kind of patients, yes, you have longer operative time, but you also have fewer readmissions, fewer staple line leaks, and less postoperative bleeding. So you have also a lower rate of complications. And if you look at this video, which is online, this is not about super obese patients. So if you look at your videos in patients with a big amount of fat, big stomach, you may, discover something, as I did during this presentation, that if you have articulating tips, if you have a big and large instrument like the Versatility, if you have a bipolar in your hand, you're moving 3 arms in one time, you're moving the camera, maybe you can just make some very difficult maneuvers in an easier way than in laparoscopy. And so concluding, but I have also a few slides. It's clear, it was clear more than 10 years ago from the evidence coming from Professor Giulionotti that if you are using the robotic platform for a patient with a BMI over 50 or 60, you're not doing anything wrong because you are as safe as if you're doing a laparoscopic procedure. And other evidences are showing even that, yes, you can have longer operative times, but maybe you can have fewer complications in these patients and you can have an easier operation, which is important. I want to show you just two brief videos. This one is not clearly from super obese or super obese patients, but it's just a demonstration how you can easily perform a fully robotic gastrectomy because you have this big and large instrument. You can easily lift the stomach, reach the duodenum. You can easily also move away the fat, the omentum. You can easily coagulate these big vessels, which are even bigger in a super obese or super obese patient. You can visualize the left crust, and all these maneuvers, they are just easier because sometimes in a super obese patient you need 2 assistants. You need a good cameraman following you. You need someone lifting a big lever. You need someone lifting with you a big fundus, doing a counter traction on the omentum. All these maneuvers, this is just a solo surgery, an easier surgery when you use the robot. Another important point is about the stapling, because of course when you use the robotic platform, it also reads the depth, the thickness of the tissue, which is quite important if you have very big stomach, if you have a male patient with central obesity, big stomach, thick stomach, and it's sometimes difficult to choose the proper cartridge in laparoscopy. The robot may help you with also with this topic. And as you can see, we also reduced the thickness of the cartridges, because now we use all blue, and we are thinking about using white one for the last stapling. And as I told you, this was not high BMI patient, but in this case we have a male patient, big stomach. The BMI was not 50 but almost 50. This shorter video, I just wanted to show you this maneuver. If you have a big liver, big fundus, you have to visualize the angle of ease, the short gastric vessels. You have to coagulate the gastric vessels, visualize the left crust. It's just easier because you have two arms on your left. You are lifting the liver, you are lifting the fundus, you are coagulating, these big vessels. This part would have been very, more difficult with a laparoscopic approach. And you also had this big discussion about time, about the training. Do we need to do a robotic training, or do we need to train the patient, the trainees also in laparoscopy? It's just history repeating itself. This is one of the first publications about the laparoscopic gastric banding. One of the first surgeons placing the gastric band laparoscopically was Dr. Cadiere. And look at the mean skin-to-skin time. 2.6 hours. I'm sure that at that time there were a lot of open surgeons. They were saying, "Oh, this is a waste of time. I can do a mini laparotomy, use my finger to do the retrogastric tunnel. I can place the band in 20 to 30 minutes. It's the same operation with the laparoscopy, it's just longer. It's a more expensive procedure." And 30 years from this paper, there is no doubt that you have to do a laparoscopy instead than open surgery in a bariatric patient. I think we are going in the same direction with robotic sleeve gastrectomy. And we have also seen that now we have evidences saying that you have lesser complications with the robotic platform when you operate on BMI 50 or 60. But I want to answer the question from the social media. He said that he showed, his article is going to show no difference in between laparoscopy and bariatrics, and robotics. But that's not the point, because we have to see what outcomes as he measured, because it's difficult sometimes to measure this, to measure the fact I'm 40. I turned 40 this month, and I must say that when I operate, if I have to do 4 or 5 or 6 sleeve gastrectomies laparoscopically in high BMI patient, maybe at the end of the day I'm quite tired, my back is sore. That doesn't happen if I do all robotic procedures. So the ergonomics, the role of the surgeon and the easiness of the procedure should also be measured and taken into account. Thank you very much for sharing your time with me.
Amazing presentation, Dr. Vitiello. And I think, sometimes researchers fail to count one more thing. As robotic surgeons, we do not need any assistance, like you stated, right? You're your own best assistant. And the cost of the assistant, the cost of another human holding your liver, the cost of another human in the operating room doing something, that also needs to be taken into the account, and sometimes it fails to do that. So in your view, as Dr. Bernante was asking, the super obese patients still you would do robotically, right?
Yes. And about the costs, I think, this is going to change very soon, because, now we have one platform. We have, not one platform, but we have one platform which is dominating the market. This is going to change in next years. And also we are publishing our cost analysis and the comparison in between laparoscopic and robotic sleeve gastrectomy. I can anticipate that the cost of robotic sleeve gastrectomy in my hospital is the double than a laparoscopic sleeve gastrectomy. Of course, it's more expensive, but it used to be the triple 3 or 4 years ago, or 2 years ago when we started. And the cost of the instrument is going down, the deal with the company is changing, we have other companies coming in, and as I showed with one of my last slides, I think that the cost of laparoscopy were quite higher at the beginning, and for sure laparoscopy is more expensive than open surgery, but we still prefer to do everything in laparoscopy or mini-invasive surgery.
Any other questions from our distinguished moderators?
Yes, Dima, may I ask to Antonio, the first question that he shared with me, even by the social media, is which kind of liver retractor do you use in robotic sleeve in super obese patient? This is the first question. And
I don't think, sorry.
Yeah, no, let's go.
First of all, just want to say hi, and I'm happy to share this, this webinar with Prof. Bernante. And we don't use any specific liver retractor. There are some surgeons also in Italy, they have an accessory trocar for a liver retractor, but we use the arm one. As you have seen, we use arm one for almost all the procedure as a liver retractor. Then when you have to retract the fundus, you can do both things. You can retract the fundus and the liver at the same time with the robotic arm, because you're just more powerful, with the robotic platform. It's difficult when you have to do that in laparoscopy. You need someone lifting the liver and sometimes someone lifting the liver and the fundus while you also retract the fundus. As you have seen in my video, you can use the two arms of the robotic platform to do these things just with, you're a solo surgeon at the console and you can do many things in one time.
Yes, it's a good tip that I agree with you, and yes, it's a good choice. And there's another comment from the social media from Dr. Rogula, and he talks about a situation that you can find. And personally, I find this situation just this morning when I do this kind of operation. He says, in my personal experience, the robot particularly helps me with revision sleeve to bypass. In particular, when I have to gently dissect and release usually retracted sleeve from the mediastinum, just a hiatal hernia of the sleeve. And what your opinion regarding this particular situation?
I've done a very few, I think 4 or 5 hiatal hernia repair with the robot, but that's another point in which, the articulating tips of the robot, the strength of the robot helps you very much. So it is quite demonstrated in literature that when you have to do a combined procedure, hiatal hernia repair and conversion, hiatal hernia repair and sleeve gastrectomy, using the robot, it just makes everything easier. And the results are also better. So there is no doubt that the robot helps you with this matter.
And Dr. Bernante, I want to comment on that question that unfortunately not always we know what we're going to find. And I think when we buy yourself to a certain technique like laparoscopic sleeve gastrectomy, and then you found hiatal hernia, or especially in those revisional cases that you have to convert to bypass, but the upper portion of the sleeve is in a hiatus, and then you're struggling. That's why I am in a batch of surgeons that would do any sleeve robotically, and I can tell you from my perspective, the liver retraction is maybe many of you know I use liver hammock, and I think at this point in time I have probably 1,500 consecutive liver hammocks on obese, super obese, high BMI patients, everyone. So I used Nathanson liver retractor probably 6 years ago last time. But agree completely that you never know what you're going to get into, and the articulation and the 3D anatomy that you can see inside a hiatus will help a lot to perform a better dissection, better surgery, and better conversion or revision. Any other questions to Dr. Vitiello? Excellent. If not, I would like to state and thank to our distinguished moderators, Dr. Cadiere, Dr. Bernante, Dr. Volpe, and our presenters, Dr. Altieri, Dr. Camacho, and Dr. Vitiello, for amazing presentation. I think we all learned so much today, and if you have your own kind of ideas about something, I hope the presented data helped you to confirm your own suspicions, your own suspicion, or your own idea, or you learned something else, and we are quite happy to participate in this ongoing International Bariatric Club lectures and webinars. And I would like to thank you all and hand over to Professor Ortiz to close our webinar. Thank you for joining us.
This has been an IBC Oxford University Hot Topics in Surgery production. I want to thank my co-chair, our moderators, and our distinguished panel of experts for their valuable time and talent today. We want to acknowledge all our partners and sponsors as our global collaboration produces safer and better outcomes. To view the complete Hot Topics in Surgery series, subscribe to our IBC YouTube channel and follow us on our social media platforms. And don't forget to mark your calendars as the 7th IBC University of Oxford World Congress is taking place September 15th through the 17th of 2026 in the University of Oxford, UK. For more information, go to ibcclub.org. And now let's view another brief episode of IBC's exclusive Spotlight on Industry and today's sponsor. From IBC Global, stay safe and God bless.
Intuitive Da Vinci 5 is our most advanced and integrated system ever. It's going to transform surgery for surgeons, care teams, and patients.
Well, I've never seen anything like this before. Force feedback is a first-of-its-kind technology. In preclinical trials, we're seeing up to 43% less force on tissue. That translates to gentler surgery for patients.
Before, we relied on visual cues primarily. But now with feedback, it does give you that extra sort of sense.
It's not something I've seen with any other system. It's something we experience in open and laparoscopic surgery, but not robotic surgery.
We're going to be able to control so many more things from the surgeon console now, which I think is really important.
It's really an immersive experience that gives you a next level of control that you didn't have previously.
The ergonomics, the ability for me to move the headset where my head goes in and move it exactly where I want it to be in a variety of different positions. I think that really is going to help elongate my career and make surgery more comfortable.
We are seeing Da Vinci 5's capabilities result in faster surgery, which translates to our customers' ability to do more surgeries in a day.
I think having the integrated new components will make the process of starting the case a lot more efficient.
The insufflator being in the vision tower is just a huge thing.
We don't have multiple vendors within a tower. We literally can offer everything that we need for the patient under one umbrella.
I think it will make rooms more organized, so it helps with the staffing problem that we have, and also helps to reduce the cost.
Da Vinci 5 will help surgeons unlock new answers to surgical techniques and patient outcomes with unique and granular data. Da Vinci 5 connects more data than any other platform that I'm aware of and allows physicians and their administrators to link them to patient outcomes.
This opens up an opportunity for years of innovation and years of things that are going to come next.
I can't wait for surgeons to get their hands on this.
Now we have a platform, an approach to do minimally invasive surgery that is beyond anything that we could have seen in those incremental improvements. And that is what's giving us the magnification, the stability, dexterity, ergonomics, precision, all of which are key for us to be able to provide the highest quality minimally invasive surgery that we can to our patients.
We don't want to be behind in medicine. We need to be ahead, and that's what's really exciting about this next generation.